Hello. So today we will be discussing traumatic brain injury and spinal cord injury. So some just basic information that we will discuss in this lecture and some background information is obviously traumatic brain injury or TBI is going to be caused by an outside force that impacts the head hard enough to cause the brain damage. So some examples of how this may occur would be motor vehicle accident, falls, gunshot wounds, sports, physical violence, etc. Um, and then we will differentiate between a closed head injury versus an open head injury in just a moment. And then just a point of reference is that TBIs can coexist with spinal cord injuries 25 to 55% of the time. So you think about individuals that maybe had a motor vehicle accident, right? They occurred or subsequently had a spinal cord injury. They could have also hit their head, developed a concussion. And we'll talk about how concussion plays into TBIs. So typically, essentially with the mechanism of injury, you have your acceleration, deceleration, rotation, shearing, penetrating, hoop, and counter-coup ways in which the brain is injured. So acceleration, deceleration means essentially the brain actually was moving really fast within the skull, right? It hit the frontal part of the skull and hit the back really quickly. So this is like typical of your whiplash individuals. Rotation, that could be if maybe they were hit with a baseball, a bat. So basically the brain turns within the skull. Steering again is the brain is moving within the skull and it rubs or there's a lot of friction that's occurring between the brain and the actual skull. Penetrating would be like your gunshot wounds if you have a knife wound to the to the brain. And again, counter coup, you'll see that more in like again NBA whiplash. The difference between this and acceleration, deceleration is that there's an actual contusion that is at the site of impact. So if the individual, if we open up their brain, the coup would be there would actually be like bruising on the skull for where the brain hit that area so hard. Okay. Some secondary injuries. So when we look at mechanism injuries, that's the primary injury, right? So the gunshot wound to the brain is the primary injury of why this individual is in the hospital. So secondary things that may occur after a traumatic brain injury is that you have the cerebral edema, so that's the swelling of the brain. You have hemorrhaging, increased intracranial pressure, and typically that is due to your swelling or if it's a bleed, hypoxia, so loss of oxygen to the brain, hypotension, so individuals develop low blood pressure, which decreases the perfusion and blood circulation to the brain, hypothermia, electrolyte disturbance, seizures, infections, and vasospasms. Infections are essentially going to look at directly if there's a penetrating wound, so there's a gunshot wound. If there's an actual open wound or open injury to the brain, is when you typically will have an infection present. So some characteristics of TBI. So we'll start with we have mild, moderate, and severe. So your mild TBI means that the individual typically has a loss of consciousness less than 30 minutes. Typically, you'll see mild TBI is classified as concussion. So that concussion and mild TBI will be used interchangeably. They have a Glasgow coma scale of 13 to 15. No CT is necessary because there won't be any results. The majority of TBIs are mild. And then, so some of the deficits that the individual may experience would be memory loss, headache, vestibular symptoms, and sleep disorders. The thing about this is that these symptoms typically are going to resolve pretty quickly. Pretty quickly meaning within a couple of weeks. So if the individual had a brain or had a concussion develop on February the 1st, 2024, they would expect by April the 30th that those symptoms have resolved. Right. So the memory loss that they experience typically is short-term memory loss. They typically have headaches. Vestibular symptoms means like they're going to be dizzy. They may have loss of balance when they do head turns. Sleep disorders, they may have a deficit in like their sleep-wake cycle may be interrupted. So some as this I kind of got ahead of myself, but this is kind of going through some post-concussive syndrome or things that the individual may experience. I think of note, the irritability and poor attention is one thing to take in consideration. So you think about your young athletes that may be in middle school and they have a concussion and they have issues with reading, right? Um, because they can't pay attention to what's in front of them and they're expected to go back to school the next day and they have where that day is just horrible for them because they can't pay attention because their brain is really in a mode of trying to basically fix itself and repair itself. And um, we've kind of already kind of gone through this. You can read this on your own. So going to moderate TBI, this is going to be a Glasgow Coma scale of 9 to 12. Loss of consciousness typically is greater than 30 minutes. If doing a CT scan, they will have abnormal results. These individuals typically have physical, cognitive, and behavioral symptoms for several months, or they can be permanent, but they do have a prognosis of good recovery, and they also may have some post-concussive symptoms. So when we think about moderate TBIs, these are the individuals we're typically seeing in like our inpatient rehab settings, right? And so when they say that they have physical, typically they may be moderate, moderate max moderate men assist with mobility. Obviously, the cognition, they have difficulty with attention to task, dual tasking. They may be, in terms of behavior, they may have outbursts. So, talking about like your Ranchos 4 individuals, those may be the individuals that we are discussing, which we'll talk about in a separate lecture, that have those issues with behavior and outbursts and out of proportion response to stimulus. Right? Characteristics of your severe TBI. You will have injuries that will be of focal and diffuse, but throughout the cortex and brainstem. So what I failed to mention with mild and moderate TBIs is that those individuals typically have a localized area. So it's typically like it's just the frontal lobe or it's just a temporal lobe, or maybe frontal and temporal, right? If they have a rotation component. Um, but with severe TBIs, typically it's globally. It's usually every lobe in the brain has been affected. So typically these individuals have a loss of consciousness, it says, for hours, days, months, or years, and Glasgow Coma scale of less than 8. Because the deficits are so widespread, typically their limitations are going to be permanent. And so these would be individuals that you would see being taken care of full time by caregivers, maybe nursing homes as well. For the purposes of this lecture, we're just going to discuss TBI, SCI, some of the terminology. We'll talk about like the Glasgow that I've mentioned, like Glasgow Coma scale, loss of consciousness, Rancho's Los Amigos scale. We'll talk about separately in a smaller mini lecture, so you have that information there. Okay. So disorders of consciousness. So disorders of consciousness are essentially when the individual has had a brain injury and their sleep-wake cycle has been interrupted. So there are 3 different levels, and so the one that is used most often or talked about most often is the coma. And so this individual does not have a sleep-wake cycle. Their eyes remain closed and there's no spontaneous or purposeful movement. The difference between that and a vegetative state is that there's resumption of sleep-wake cycle, but again, they have no spontaneous or purposeful movement. They can have their eyes open or closed, but again, um, there is not activation of any purposeful movement because they're not aware of their environment. And then you have your minimally conscious individuals, which means their eyes are awake. They have sleep-wake cycle that is present, and then they're able to be aware of their environment. So there's different levels to this. So they can track, they can respond to stimulus. Um, they can have some purposeful movements. Is how we look at a minimally conscious individual. Okay. So kind of going back to those individuals that have like those behavioral issues. Again, we'll talk about this in your Ranchos Local Meals or mini lecture. Is that these individuals typically are going to have erratic behavior. So we're going to talk about how you want to what type of environment you want to have them in. We're going to talk about, so since you want to have them in a closed environment, you want to have them away from other individuals so nobody can interrupt your session. Obviously, you want to remain safe. You're in a safe distance, but you want to have them away. You want to give them slow commands, simple commands. If they become upset or they start to have an outburst, you will try to de-escalate it, right? If you cannot de-escalate it, then obviously you're going to stop the session because having their behavior in check is going to allow you to actually make more gains than trying to just push through the session. And sometimes a simple thing of just changing what you're doing. So the individual's having difficulty with putting objects in a cabinet, right? Or it's usually they're having difficulty with doing it an abstract thing. So they're putting pegs in a board. They don't understand why they're doing it, but oh, okay, Mr. Jones, can you go get the cup out the cabinet? It's the same concept or a similar concept, right? But it's redirecting their attention. And so a lot of the questions that you will see about Renchos will either be about how to maintain safety or if you can identify the level. So we'll talk more about that in that mini lecture. Okay. So that is the basis of TBI. Really, TBI information is the big things NPTE wants you to know is the Glasgow-Coma scale, which I said we'll talk about more, the Rancho scale, the mechanism of action, and then what are the prognosis, right? So in mild, when you're just concussion, obviously you have a prognosis that you should return to normal activity within a couple of months. Moderate, you have where those individuals should again recover in a couple of months to up to a year, but it may take some time and they may have some residual deficits, right? Whereas when we're talking about severe, we're not expecting those individuals to have any type of changes in terms of their deficits are going to be permanent. Whereas we look at spinal cord injury, so transitioning to spinal cord injury. Spinal cord is a little bit different in terms of the information. So the beginning of these slides, you have this information. I won't read it to you, but basically this is just going over how you differentiate a tetraplegic from paraplegic and what that means essentially, right? So tetraplegic means you have some type of involvement in your arms. Paraplegic means you have no involvement of your arms, but you may have your abdomen and legs that has involvement. This just talks about your spinal cord anatomy, just some basic background information, how the spinal cord works. Again, we'll have a separate mini lecture that goes over the actual pathways, which we'll get into this a little bit more. If we talk about, there was a segment in the PNF lecture that talks about like your muscle spindle fibers. This is very similar to that. But this kind of gives you a background information of when we talk about dorsal root ganglia, we're talking about sensory fibers. Whereas your ventral root ganglia, that's where you have your motor input, right? So it's just a system of how things work. Again, in a separate mini lecture, we'll have that information for you to be able to consume. The big thing that you will hear is your ASIA assessment. So your ASIA is your impairment scale that you will utilize. So within the clinic, this is a typical ASIA form that is utilized. And so what you will not be asked to complete this on an exam. But what I do like about this for you to review is it gives you information in terms of where you would test the dermatome, right? So where you would actually test some of that sensory information because the ASIA exam is sensory as well as motor. So this gives you a good example. So each one of these dots is representing where, okay, for S2, I'm going to be right in the popliteal fossa to actually test that, right? And if I'm looking at L4, I'm going to be on the lateral malleolus, right above the lateral malleolus. If I'm doing L5, I'm going to be between the first and the second toe. This gives you exact point of where you would actually test the dermatome, which is important not only for spinal cord injury, but you'll see those questions correlate to musculoskeletal one. Maybe they talk about the individual has an L3, L4 disc herniation and ask you, well, what dermatome, where would you test this individual's sensory or sensation, right? You also see here where my cursor is that you have your C5 to T1, L2 through S1. That information is denoted of what you would actually be testing. So C5 is elbow flexion, C6 wrist extensors, C7 is elbow extension, finger flexors, C8, and then finger abduction is T1, hip flexion is L2, knee extension is L3, ankle dorsiflexion L4, long toe extensors is L5, and ankle plantar flexors is S1. So when you are reviewing this information, this will be very similar to the musculoskeletal information. So the dermatomes and myotomes have not changed. It is just how it's formulated within this document. So this, if you have not gotten to musculoskeletal, is a good review. If you have got, or will be a good introduction. If you have done musculoskeletal, then this will be a good review for you. Okay. So this is just the back of the form and how it's graded. Again, you will not need to know how it's graded. The important information is, again, the dermatomes, where you're testing on the dermatomes, and then these myotomes here, the motor component. Okay. Again, this just gives you some terminology that you can review. So you should be very familiar with dermatome sensory. Myotome is the motor. So if we're talking about, when we go back to this slide, when we're testing the dermatomes, we're testing the dorsal root ganglion because that has sensory information. When we're testing the myotomes, we're testing the ventral root because it has motor information. Okay. So your sensory level, when we're looking at the ASIA, sometimes you'll have a sensory level that is different from motor in real life. But for NPTE, they are only going to be testing you on complete injuries. Okay. So this information just is more detailed, not necessarily for background information, but this won't be tested on NPTE. Complete versus incomplete. So the reason why they utilize complete injuries is that incomplete injuries are difficult to quantify. So the only incomplete injuries that you will discuss will be anterior cord, central cord, posterior cord, Brown-Sequard syndromes. Those will be the only incomplete disorders that you will test of the spinal cord because they're difficult, because the other ones are difficult to quantify, and they're not going to give you where you have a sensory level that's higher than a motor then higher than the sensory, because again, that information is going to be difficult to quantify. Even on the case study questions, it'll be different. So what I want you to know about complete versus incomplete is that obviously complete means that you have no motor or sensory below that level, no sacral sparing. So sacral sparing is essentially a way that is a test that is done to essentially establish if you have complete versus incomplete. And basically, it is done by establishing if the individual has anal contraction. If they have the contraction or they're able to voluntarily contract their anus, then that means they're incomplete. If they cannot voluntarily contract or they're flaccid, then it means that they have a complete injury. Another thing to take note of is typically complete injuries have a worse prognosis, meaning that the individual typically is going to have more infections that they develop, may have more difficulties with breathing, and have a shorter life expectancy than individuals that have incomplete spinal cord injuries. So when we look at spinal cord injuries, you will see the classifications A through E. So A means the individual has sensory and motor that is complete, meaning that C5 is where my sensory and my motor stops. There's nothing above, there's nothing below. Right? Whereas when we start to talk about your Asia B, that means you have sensory incomplete, meaning that my motor may stop at C5, but then my sensory goes to T1. Right? Again, because that's a difficult concept to quantify, to get a good answer for, typically the NPTE, and when I say typically, I mean 99% of the time, unless you're talking about Brown-Sequard, anterior cord syndrome, central cord syndrome, or posterior cord syndrome, they're going to be sticking to your complete injuries. Okay. So some things to take in consideration that are going to occur that is post spinal cord injury is that typically right after, and for the first 24 to 48 hours, the individual's in spinal shock. So typically they have no reflexes. So the ASIA assessment should be done 24 to 48 hours after the individual has been diagnosed or stabilized for spinal cord injury, because everything will be flaccid. So they'll have no reflexes, they'll have flaccid extremities. So they start to get return is typically after that 24 to 48 hours. So the first thing that returns for male will be your bulbar cavernous reflex. Um, and so um, that one is something that they can test. Um, but typically the one that they're actually looking for is your perianal sphincter reflex or your sacral sparing. So that's when they see if you have voluntary or anal contraction. Okay. So medical complications that can develop, we will talk about the ones that are most discussed directly related to spinal cord injury, and then some of these we will not get to. The ones we will not get to, which are similar to ones we talked about in other lectures, we won't talk about pulmonary complications, depression or psych, sexual dysfunction, infertility, endocrine abnormalities, and neuropathic pain. Some of them we will talk about in other lectures, so pressure ulcers, musculoskeletal, neurogenic bowel and bladder. We'll talk about that when we get to other systems. We'll talk about some incontinence information. So we're going to hit on the things that you'll be testing on directly. So autonomic dysreflexia is a medical emergency, and essentially what happens is this is going to occur with individuals who have a T6 or above injury. So again, T6 and above is going to give you a good idea that they have autonomic dysreflexia. And so what occurs with this individual is that we talk about sympathetic and parasympathetic balance. So if you recall, parasympathetic balance is your rest, right? Is we rest and digest system, and parasympathetic is like when you have increased heart rate, increased muscle contraction, you have increased blood flow to those vital things that are going to help you with your fight or flight. So if you have an individual who has T6 or above injury, they don't have a good pathway for sympathetic and parasympathetic balance, right? So if something happens, meaning if I stub my toe, I hit my toe on the side of the bed, my sympathetic nervous system is what tells me I need to take my toe away and that I'm in pain. So what occurs is in a healthy individual is I stub my toe, I have that sympathetic information that's increased. My parasympathetic information basically increases as well to basically create homeostasis or a balance between the two. Individuals that have spinal cord injury T6 and above, they don't have that balance. So they have that sympathetic information that's coming in, but they can't get that parasympathetic information to the extremity because they have a traffic jam. So a lot of times I will talk to students in terms of thinking about what a spinal cord injury is a traffic jam in the spinal cord. So I have a traffic jam at C6. So that means that no signal can get from my brain below C6, right? So because you have this traffic jam in your spinal cord, you can't get that parasympathetic and sympathetic information to relay as normal. So you can develop is a medical emergency, so you could possibly develop or have a stroke, you could have seizures, encephalopathy, a retinal hemorrhage, a retinal detachment, an MI, pulmonary edema, or it could end in death if the individual is not treated. So how this presents is that the individual has elevated blood pressure, headache, they have bradycardia, can have piloerection. The big thing is that they will have sweating above, so they will be red, sweating above their level of injury. So their level of injury is T1. They'll be sweating and red above their level of injury. They'll have flushing there, but they will be pale below. Right? So pale compared to what they normally are. Right? So you have the sweating and flushing above the level of injury, and you have paler below. So how we manage this is one, when I'm doing a chart review on a patient and I see that they have a T1 spinal cord injury, my thought process should go to they could develop autonomic dysreflexia at any point. And we'll talk about why that is in the next slide. Okay. Once I have that on my radar, I'm keeping that in my mind at every session. So how you treat this as a therapist is you want to make sure the patient is sitting up. So whether they're in a wheelchair or you have the bed head of the bed, so they're in a seated position, they need to be sitting up. You want to identify what is causing this. the noxious stimulus, and we'll talk about that again in just a second. You'll monitor their blood pressure for 2 to 5 minutes. And then if you are at the hospital, you will let them know that they had an event. They will continue to monitor their blood pressure. If you're in an outpatient setting, typically what we recommend, and this is not NPTE related, but just for your knowledge base, you recommend like just go to the EC, emergency department, or if it's early enough in the day, your primary care, tell them that you had an incident of autonomic dysreflexia so that you be checked out. And then there's medication that can be given, which we're obviously not giving. So the three big things we're doing is sitting the patient up, removing the stimulus, and identifying and removing the noxious stimulus, and then checking the blood pressure to make sure the blood pressure is going down. Some of the common causes for autonomic dysreflexia or urinary retention. So a lot of these individuals have overflow bladders. We talked about they have a neurogenic bladder and bowel. So did they have their bowel movement or are they constipated? Obviously we're not removing that, but they should have some mechanisms for that. So constipation, have they cast? Is there Foley clogged? Do they have appendicitis? If they're a woman, are they going into labor? Do they have a fracture? They stubbed their toe. We talked about that. So they don't know how hard they did it because they can't feel it. Did they have a fracture? A typical one is an ingrown toenail. UTIs are very common. Bladder stones are very common. Okay. So the reason why we hit on autonomic dysreflexia is there's typically is going to be one question that's going to ask you to differentiate between autonomic dysreflexia and orthostatic hypotension. So remembering that from when we talked about cardiopulmonary in the cardiopulmonary section, that orthostatic hypotension is typically caused by a change in position. So going from supine to sit to stand, right? So my blood pressure decreased because I changed position. Thus, I needed to return to my previous position to get it monitored. Whereas in autonomic dysreflexia, the cause is I have an ingrown toenail that I've had for 2 years that has caused me to have autonomic dysreflexia, which caused my blood pressure to increase, which I need to sit up to actually alleviate and then get rid of the ingrown toenail. Okay. So long slide, but it is a big differential diagnosis question. It is usually one, but because you know that going into the exam, it's an easy question to get right because you have a clear picture of what these two different concepts are. And spasticity, right? Typically, you will see spasticity um, with individuals that have spinal cord injuries because spinal cord injuries are upper motor neuron lesions. And so, because of that, they have increased spasticity, which you're going to assess that through the modified Ashworth scale we previously talked about. Um, so I would be familiar with the modified Ashworth scale. And then your treatments are typically going to be your PNF patterns that we talked about earlier on a different lecture, rather. And then there's some oral medications that you can give. Baclofen is the most common one that you will see on the exam. So knowing that baclofen can reduce spasticity, but it also can reduce overall muscle strength. So if I am a T1 individual, which T1 Asia A spinal cord injured individual, right? I have all of my upper extremities, but maybe I have spasticity in my upper extremities that need to decrease. Well, if they give you too much baclofen, basically it will cause your extremities your muscles to be flaccid. And so then you won't be able to do your transfers independently. So there is a fine line between that. But the biggest side effect that you need to be aware of is that those individuals could develop increased muscle weakness. And then you will have some of the same common musculoskeletal injuries that we talked about or will talk about in the musculoskeletal lecture. So rotator cuff impingement syndrome, rotator cuff tear, bicep tendonitis, epicondylitis, osteoarthritis fractures. So the treatments that you will do for those individuals that have a rotator cuff tear will be the same if they have a spinal cord injury if they do not. It's just obviously if they are, again, T1, they use their arms for transfers. So if they have a rotator cuff tear and they have surgery, then obviously they go from being independent to dependent. Whereas in a non-spinal cord individual, injured individual, it wouldn't impact their independence level, right? So that is just something to take into consideration. Okay. So big thing about spinal cord and TBI is that a lot of the questions for TBI are going to be related to, like I said, the the stratification of mild, moderate, severe. With spinal cord injury, is going to be related to the their level of injury, you know, differential diagnosis between autonomic dysplexia. There may be some modified Ashworth questions related to it. Again, in a mini lecture, we'll talk about the levels of independence, which is a big thing you need to be able to understand clearly. So those are some areas of big concern. These this lecture is to give you a synopsis of the information, with the smaller lectures being more digestible that you'll review subsequently, so that you can understand this information in this folder. Right. So thank you for listening, and I will talk with you soon.